Happy Thursday Night Live. And look who I have with me today. She is a really famous sleep doctor from not only Instagram, but from Bellevue, Washington. We're so excited that you're here with us, Dr. Meredith Broderick. Thank you so much for joining us on Airway Circle.
Thank you for having me.
Introducing Dr. Meredith Broderick, a triple board certified sleep neurologist and one of only 4 practitioners in the world to hold board certifications in neurology, sleep medicine, and behavioral sleep medicine. She owns and operates a solo practice, Sound Sleep Guru, located in Bellevue, Washington. Today's topic is your sleep problem isn't in your head, it's in your mouth. I love that. You're welcome to share your screen. And did I miss anything? I know that you just mentioned that you didn't share about your MARPE journey on this presentation. However, we got to know each other because I was going through the MARPE and we connected on Instagram.
Yeah, and then we met at the dentofacial conference
And then we met at the dentofacial conference. That's true.
Yeah.
How long has it been since you removed the MARPE?
I think it's been a little over a year.
A year. However, you didn't finish the treatment, right? Because you had complications.
No, I finished it, and then I had my tongue tie release and did my myo.
Very good.
So I'm done.
Are you feeling better? Did you get any changes in your sleep?
Oh yeah. I mean, I don't have to wear a CPAP anymore, which is huge. Yep, my nasal breathing is better. Obviously, there's an aesthetic benefit in terms of just wider smile.
Mm-hmm.
I think my dental health is going to be better because I don't have like the overlapping, so I'm not going to get as much plaque buildup. And I mean, you could probably speak to that better than I could, but I'm I'm so glad I did it. It is a commitment, but
Mm-hmm.
I'm so glad I did it, and I'm so glad I had you because you were ahead of the process. And it really helped me see that all the sort of anxiety or questions I had in my mind, you were talking about them. And so I just love it how you put out so much about that, especially as, as a healthcare professional, that was so valuable.
Oh, thank you very much. All right, the floor is yours.
Thank you. Well, I'm so grateful to speak to you today and have the opportunity to teach you how to become a great sleeper, to share the holistic approach that I use in my clinic as a neurologist, as a behavioral sleep medicine specialist, and as a sleep medicine physician. This is really an opportunity to use this information for ourselves and for our children. So here we go. So, just to tell you a little bit about me, this is a picture of me as a newly minted MD. My parents adopted me from Korea when I was 6 months old. And from a very young age, I wanted to be a physician. And your real training as a physician begins when not in medical school, but in your residency. And so, when I look back at this photo of myself, I feel compassion for the transformation that I'm going to go through, not only as a physician, but in learning more about me and the sleep disorders that I struggled with and ultimately was able to address by becoming a sleep medicine physician. But the reason I chose sleep medicine is in my primary specialty as a neurologist, I encountered a lot of people that had strokes that were dealing with devastating neurological conditions like neurodegenerative diseases. So that's Alzheimer's disease, Parkinson's disease. And I almost had this existential crisis in my neurology training, thinking like, wow, it's very hard to cure these things. We don't have cures for these things. What can we do about it? So I had a visiting rotation at Stanford, and I know that some of you have been there. And it's this incredible place where the mission is really trying to prevent neurological disease. And one of my main teachers there, a very famous sleep doctor named Christian Guilleminault, his whole MO and something that I took away from that training was we need to work very aggressively to prevent neurological disease, and we can do that through healthy sleep. So let me talk to you about a roadmap and share some of what I learned about how to achieve healthy sleep. I'm going to make it really easy for you, and we'll just use this acronym ABC. So the A is going to be awareness, and I want to talk to you specifically about what that looks like to me, why I'm on social media, why we're all here, and to share my perspective from my little vantage point as a neurologist, which may be a little bit different if you're a myofunctional therapist, if you're coming from the dental field, if you're a health coach, and for any of you, if you're just a parent or not just a parent, if you're a parent, you might think of that a little bit differently than I do. So I want to share that. I also do want to talk about breathing. I think of sleep apnea and sleep disordered breathing as the emperor of all sleep disorders and the most important. And I'll talk to you more about that. And then I want to talk to you about conditioning. And I bring that from my subspecialty of behavioral sleep medicine. And we'll talk about how that is also an important component and how all of these things support each other. So, in speaking about awareness, one of the major challenges in getting people to identify and treat sleep disorders is awareness. And what I mean by that is I always think of this myth. It's called the frog in the pot myth. And if you haven't heard of it, basically it goes like this. If you throw a frog in boiling water, it jumps out because it's boiling, it knows. But if you put a frog in a pot and heat up the water very slowly, it doesn't notice the changes and it dies because it overheats or it cooks. And I like that analogy for sleep disorders. That's one of the problems with treating it or preventative treatment is we can adapt and function very well for a long time with even pretty significant sleep problems. And because of this, one thing we need to do is really know how to perceive and show people how to recognize healthy sleep and also point out cultural biases we have, inaccurate perceptions we have about it, and to show these changes happen so slowly, they're hard to detect. People will say, like one thing I'm seeing right now in my clinic is people have really severe anxiety about sleep, but they don't know how to take the correct actions. And they're devoting a lot of energy to tracking and apps and things, but they're not devoting energy to the things that will make a difference. So let's just go over some of the cultural beliefs, perception, and biases that we come past. And so I'm going to illustrate to you 3 sleep stories: the snorer, the dozer, and the oversleeper. And this might be a little provocative to some of you, but I want you to observe some of the cultural biases we have. There is a famous sleep psychologist named Ruben Naiman, and he coined this term called wake centricism, meaning that we all have a bias towards wakefulness and against sleep. We sort of undervalue it and don't appreciate it as much. And so let me tell you some of the sleep stories I hear in my work. And let's just think about what our initial perception is of these cases and some of the things that come to mind, some of the implicit biases that we have. So let's just think about the snorer. And, these are stock images, but many of you have probably seen viral social media content. And how natural is it to laugh or make fun of someone snoring or even gasping for air? And, we've all heard someone say that when a baby snores, it's so cute, or making fun of a spouse because they're snoring so loud. Some of you have probably seen the viral videos where there's one bed partner having an airplane go, ooh, with the different snoring sounds. And it's actually, even I laugh when I see it because I think we all have these cultural biases. And then some of us are just downright hostile and angry that our bed partner is snoring, like it's something that they're doing on purpose. Then we have the dozer. So how about laughing at someone who fell asleep somewhere other than their bed? This could be someone who fell asleep in class, or sometimes even hazing someone who fall asleep, putting their hand in water, putting shaving cream on their face or their body. Or have you ever made a joke or joked about how sleepy you were when you were driving and how you had to turn up the music and roll down the window. And just think about that and whether what that means, what that tells us about our biases and how we're sort of normalizing it or making it funny or a personality trait rather than thinking of it as a medical disorder. Then there's the oversleeper. So, how many of you have felt judgmental towards someone who's chronically late, someone who oversleeps all the time, someone who pushes snooze 10 times? And you might even just judge them as like a lazy person and think that they're really not motivated. And many of the patients that I see in my clinic will recount this as part of their story of having a sleep disorder. And I think it can also be very difficult to notice this as being unhealthy because of that frog in the pot aspect where it kind of came on slowly, or maybe it was always there even since childhood. But I think it's really important to think about cultural beliefs and separating what are really personality traits or values versus what is a symptom of a medical disorder. And we all need to think about that. And even if we're aware of it as a healthcare practitioner, sometimes our patients don't realize that. And that is a barrier, I think, into convincing them to go through an airway treatment or to get a sleep study or to go see a sleep specialist. So let me tell you a real case of the snorer. And I want to tell you their real story in real life, but I just wanted to show those stock images because those stock images exist for a reason. This case was a surgical division chief, and he was constantly teased about his first wife about snoring. And he told me that he fell asleep in the OR lounge every day between his surgical cases. And he accepted this as normal because of how hard he worked. And it's actually typical for surgeons to be sleep deprived, to take overnight call. And so he just accepted this as normal. But after he got divorced and remarried, his second wife said right after the honeymoon, yeah, you need to go do something about this. This is not something I'm going to accept. So what you're looking at here is his sleep study report. And what you'll notice that really stands out is that if you look down here at the oxygen saturation, so at the bottom right, this is his tracing. And you'll notice that his oxygen saturation is going all the way down into the high 50s. So you can see up here on the right, his minimum oxygen sat is 58. And you can see, this is probably his REM sleep. That's when that happens because the airway is most vulnerable to collapse. But down to an oxygen level of 58, when I want to see people in the mid to high 90s. Now, if this person was awake, we would call 911. We would say, this is a medical emergency. So what happens to this person is the brain makes adaptations slowly over time. It's not normal to sleep through an oxygen saturation of 58. A normal brain, once you start to desaturate a little bit, will wake a person up, meaning the wakefulness promoting mechanisms will protect the person and say, wake up, you're in danger. But what's happened to this person is slowly over time, because the biological need for sleep is there, the brain tries to balance that. So what happens is that these wakefulness promoting systems are blunted. That is why people who have sleep disordered breathing, obstructive sleep apnea, develop excessive sleepiness. And sometimes it's irreversible. And the ironic thing about is many of these people will be labeled as a good sleeper. They will be told, they will say things like, I can sleep anywhere, anytime. And their bed partner might say, oh, I wish I was them. I wish I could just fall asleep when my head hits the pillow in less than 1 minute. But the reality is, this is not healthy. This is a brain that has made an unhealthy adaptation. It also is a risk for high blood pressure, stroke, heart attack, ADHD, depression, headaches. And I just want to point this out that it's very important to recognize these quote unquote good sleepers as another bias we have that is not normal. This person, if you look at his apnea hypopnea index using the AASM criteria, 3% hypopnea, he is having an obstructive breathing event 76.3 times an hour. That's more than once a minute. These events have to last 10 seconds to count. So you can just see how severe this was. One of the things I want to point out, this was a division chief surgeon. And what I'm trying to communicate to you is this is a very high functioning, successful person. That is important to recognize because, again, if we look at the frog and the pot metaphor, this person doesn't really feel like life is necessarily going bad. This sort of seems normal to the person. This person only came to see me because his wife told him he had to. So let's talk about the dozer. The dozer is a 28-year-old woman who says she was the first to fall asleep and the last to wake up at sleepovers as a child. She dealt with long-standing excessive daytime sleepiness. She was diagnosed with depression, anxiety, ADHD. She had been prescribed stimulants. They really didn't do much. She did not snore. She did not gasp for air. She was thin and otherwise healthy. She often avoided social engagements because she felt like if I don't get 9 to 10 hours of sleep, I can't function. And this is affecting my quality of life. She also notably didn't like her facial structure. She said that she didn't like her small lower jaw. She was also spending a lot of money on filler, especially like in the chin area. And she actually was diagnosed with obstructive sleep apnea as well, more into the mild to moderate range. She used CPAP for a number of years, but ultimately went and had the root cause of this corrected with jaw surgery. So this is just showing her airway. Y'all are probably familiar with these scans, but the red is just showing the size of the airway before and after her jaw surgery. So again, this person was a professional. They were doing well in life. They were going to get married, and there wasn't really anything quote unquote wrong, but there was definitely a decreased quality of life and a feeling that they were not reaching their full potential. So let's talk about the next trait. This is the owl. Um, and let's talk about the oversleeper. So the oversleeper is a graduate student who recalls being teased about falling asleep at family gatherings and is never able to make a morning appointment. You know, a lot of people look at this person and say, "What's wrong with you? Get it together. Why are you so lazy?" They describe themselves as a night owl, and they feel it makes it difficult for them to fit in with the rest of society because of their sleep habits. And at the same time, they really like being awake at night. They feel like they thrive at that time, and they feel that's their best time of night. So this person has a circadian rhythm disorder we call the delayed sleep-wake disorder. It's a genetic trait that was highly beneficial for humans to have because it helped us adapt to seasons, and it helped us to adapt to being alert at different times of the day, perhaps to protect the tribe. I really think of this as a form of neurodiversity, and I tell my patients that you're almost like a left-handed sleeper in a way, in that just culturally what we appreciate, being a morning person, being early to rise, the early bird gets the worm, is not you. So you can see this is on the right-hand side. This is what's called an actigraphy study. And so across the page horizontally, that is the clock. So it's noon to noon. So this is 24 hours. The blue is their activity. The yellow is their light intensity exposure. And then the green bar is their sleep period. So you can see this person is sleeping from, you know, somewhere around on average from 3 a.m. to 11:30 a.m. And, you know, actually, if you look at the duration, if you look at the consolidation, if you look at the regularity, many aspects of sleep health, they are quite good, but it's the timing of it that is just not aligned with culturally what we consider to be quote unquote normal. So, with those cases in mind, let's talk a little bit more about how we define healthy sleep in a holistic fashion. So, not just the airway, but there is this acronym called RU SATED that was coined by a well-known insomnia researcher who identified 6 characteristics of healthy sleep. So the first one is regularity. So the R is for regularity. How regular are the bedtimes and wake times? So I like to think about keeping it plus or minus 1 hour. So is your bedtime and the time you get awake, is it around the same hour of the night? That's a good benchmark to use. S is for satisfaction. How restored do you feel? So asking the person, how do you feel when you wake up? This is one of the problem with trackers is you don't get asked how satisfied you feel. You get told that this is your sleep score. So that's one reason I don't like trackers, or one downside I would say that about them, one disadvantage. A is for alertness. How alert does the person feel throughout the day? So not just how do I feel in the morning, but how do I feel throughout the day? You know, are there times where I feel sleepy during the day? Do I feel a sleep attack? Do I feel an urge to take a nap? Timing is also important, and timing is different than regularity. So timing is, does the sleep period align with the circadian rhythm? So you can see in the previous example, that person had good timing with their circadian rhythm. It just doesn't align with maybe what if they had to get up at 9 o'clock to be at work. Efficiency, is the person asleep 90% of the time they are in bed? So there's this concept that we're going to talk about conditioning a little bit in here in a moment, but we like to see that a person has a strong association between sleep and their bed, meaning they're asleep 90% of the time they're in bed. And then duration. Now we all think about duration, 8 hours of sleep, 8 hours of sleep, 8 hours of sleep. And the whole point of this Are You Sated acronym is to help people understand it's not just 8 hours of sleep, it's multidimensional. But duration is an important component of that. And is the person getting 7 to 9 hours of sleep? There are some people who need less and some people who need more. This is an individual trait, depends a little bit on genetics, depends a little bit on your life. For instance, if you're LeBron James, you might need 10 hours of sleep, like he said. But on average, healthiest people that have the lowest risk for mortality are going to be sleeping around 7 and 9 hours. So this is just a diagram showing the Are You Sated model with the reference from the expert, Dr. Boise, and how we define it if you want that reference. All right. So now that we've increased our awareness about what sleep health is, let's talk about some of the physiological aspects of healthy sleep and talk about the B in the ABC acronym. Let's talk about breathing. So I'll just play this video real quick. Hopefully you can hear it.
No sound.
No sound.
Whenever you share your screen, there's a little box on the right side that says allow sound to be shared. If you want to unshare and share it again, you will be able to.
Okay, let me do it.
To choose that.
Okay.
Somebody recently asked me if people need different times, amount of hours of sleep. If it's normal that somebody only feels refreshed after 9 hours and somebody feels refreshed after 6. So that's great info that you're sharing.
Okay, tell me again where it is.
Oh, so before you share the screen, as soon as you click on share, you're going to see a box on the right side before you pick the PowerPoint. You click on share. When it pops up on the right side, it's going to say share the sound also. So you got to click.
Okay, so click share.
Okay, right there. Now you're going to see a screen
Oh
on
yeah,
the
I see
side.
it. I see
Okay,
it.
awesome.
Okay. Okay. Let's try that again.
Yep. Perfect. Thank you.
Okay. So here's a video of my younger daughter to show just how seemingly harmless snoring can be. If you go to any sleep clinic, they're going to ask you about snoring. They're going to ask you about sleep apnea. And you may have experienced this, but people get really annoyed by it. They almost get defensive about it because of this perception that it's so benign. Thinking back to the awareness piece, though, if you were talking, like if I was talking to you right now and I was snoring, you would be like, are you okay? I mean, if anytime someone's having trouble breathing when they're awake, it's really concerning. And the same pathways are activated when someone's having trouble breathing during sleep, even if they're only snoring. The fight, flight, or freeze part of our nervous system, the sympathetic nervous system, is activated. We're encountering the frog in the pot metaphor again. My mentor, Christian Guilleminault, he always said, and it's kind of a provocative thing to say, but it is true, is that snoring is the first sign of cardiovascular disease. So if you're one of these people that's really into longevity, you really have to think about preventing this from the very, very beginning. We'll talk about that more. Neurologically, breathing is very complex. So in order to show you a simpler neurological pathway, I'm going to draw an analogy to breathing so you can understand why normal breathing during sleep, during childhood, is so fundamentally important. This is also my younger daughter, so that same child as an infant. And when she was a newborn, I started noticing she had what neurologists call a turn preference. So if you look at these photos, it's subtle, but you'll see that she pretty much always prefers being turned to her right side. So if that happens, and then you have a bunch of right-handed caregivers and they want to feed the bottle with their right hand, then and change her diaper with her right hand, and sleeping, eating, and getting your diaper changed is pretty much as your life as a newborn, you continually reinforce that neuromotor pattern of being turned to the right. Now, the reason this happens is because of something called torticollis. So this neck muscle is really tight. So it's a little bit unpleasant for the child to turn their head the other way. It's thought that this has to do with childbirth. And the baby might even start to resist being turned to the left, and the caregiver might avoid it because it seems painful. But what happens if you don't correct it, just this simple tight muscle, just one muscle being tight, is the growth of the face, the growth of the head will start to become asymmetrical. And the brain will not develop correctly because that child will not attend to their left visual field. So the visual pathways in the brain don't develop. This is all because of a tight muscle. So this is why we're thinking about the tongue and the oromotor development and chewing and swallowing, because think about how much even more complex breathing is compared to a simple tight muscle in the neck results in this abnormal growth and abnormal brain development. The exact same thing happens in breathing. So thankfully, a good pediatrician will catch this. I caught this really early, and as a neurologist, it totally freaked me out, even though it's easy to correct with physical therapy if you catch it very early. Um, but scary. And I want you to keep that in mind because I think it's hard to explain breathing with its complexity. How does that result in this sleep apnea thing later, which is what happens? It's a more abstract thing. It's more difficult to describe to patients, but this is very easy to see. The other example you can use is, the lazy eye is the layman's person, but the same thing happens is the compensation the person makes when their eyes are not in alignment is they use the good eye, and then the eye that's not in alignment doesn't develop and the visual system doesn't develop. And then the fallout of that is when you never had that pathway develop during these critical periods of childhood, there's only so much you can do when they're an adult. So that's why it's so important to correct this during childhood. And I know all of you feel that way too. So let's specifically talk about how that applies to breathing. And some of you may know more about this than me when it comes to the oromotor development and function. But the version of this in children when it comes to breathing is there's mouth breathing. We see this growth pattern where there is an elongation of the face, there's a recession and what the orthodontists call a downward and backward growth of the craniofacial complex. And oftentimes the root of the mouth breathing can be in part because of these enlarged tonsils or adenoids, which is lymphoid tissue in the back of the throat. And also things like thumb sucking or non-nutritive sucking. So in this top picture, you're seeing an anterior open bite. The child pictured is the sort of the classic adenoid facies. So when we see this in the medical side, we think of a child that has allergies. And then on the right, you just see these large tonsils. You see a very swollen, boggy uvula and just kind of generalized redness and erythema in the posterior pharynx. So we see that when people snore because they have that vibratory inflammation response from all the snoring at night. I want to say the other thing is you can see the mentalis strain, you can see the lip incompetence. And I want to say I could easily have put my picture there as a child to be the poster for this. So I feel, it's sensitive talking to people about their facial structure. And so that is just something I want to mention. In many ways, this is an epidemic problem because of modernization, the convenient options we have. I know this very well as a parent. It's very easy to just give kids a pouch on the run, to have all these sippy cups so they don't make a mess. And so we're eating and drinking. We're not using our orofacial muscles the way that they would have in our hunter-gatherer times. A lot of you I know have probably read the book Breath by James Nestor, where he talks about anthropology and how if you actually look at skulls from humans in like the 1500s, they did not need teeth extractions. They did not need orthodontics. They did not need their wisdom teeth pulled. And we did a lot more chewing and a lot more probably breastfeeding. And we didn't have all this, pureed food. I want to clarify some things about obstructive sleep apnea in children. The prevalence is about 1 to 5% of kids. And even though the craniofacial structure is so obvious sometimes, it is not 100% predictive. So you can have a child or an adult and you can say, oh my gosh, I just know you're going to have obstructive sleep apnea, that you just, you have that adenoid facies. But the physical exam is only 45% predictive. And I think the reason for this is because, like I was talking about earlier, the mechanisms and the neurocircuitry for breathing is so complicated. And because we are so able to make compensations for children, in lab sleep testing is the gold standard. I do use home testing in kids with FDA approved products. But there's a little bit of controversy about that. It's not, I think, mainstream. I think, the problem with using home testing in some settings, I feel as a sleep medicine physician, is people are just sort of auto scoring using like an algorithm to score it. They don't know how to identify artifacts. They haven't been trained in looking at electrodiagnostic testing. And so, not to badmouth anybody, but this does happen sometimes with dentists where they're testing and they don't really know how to read the studies. And so I think that's important. That's something I would say, especially if you are going to look at perhaps using home testing in kids, is you need to have somebody who knows how to identify artifacts and look for quality data and can read it beyond using some kind of, scoring mechanism. We also should be aware that Black Americans have a 2 to 4 times higher risk of sleep apnea. Prematurity carries a 3 times risk, family history, 3 times risk. And what does this look like in kids? It looks different than in adults. We see more attention learning behavioral issues, executive functioning issues, academic problems, restless sleep, bedwetting, quality of life, failure to thrive, insulin resistance, obesity, high blood pressure. I can tell you in my case, I was always late to school. I was tardy all the time. I had to take a nap after school every day, which just annoyed the living daylights out of my mother. And so um So the reason it's important to identify in children is they have not had decades and decades and decades to make unhealthy compensations. They're still growing. Think about me noticing the turn preference in the first 2 months of life. All I needed to do was stretch out that muscle in my daughter's neck. But if I hadn't noticed it, she might have had to wear a helmet, which isn't that bad. But we might have been dealing with developmental delays because I'm not using the other side of my body. I'm not using that visual field, and that can affect the entire pathway from, the arm, the visual field, all the way into the brain. Think of this like teaching a child to learn a second language when they're young. The networks are so much more flexible when we're children. That's why we want to address this in childhood, like teaching a child a language earlier. Okay, so I'll wrap this up and just let me know if you want to end early. I think I only have 3 more slides. So, because I know we're almost at 45 minutes. So the third step is conditioning. So I'm going to play this video.
Hi, baby. Big smiles. Oh, I'm all lined up. I'm all lined up. 1, 2, 3. You did it.
Okay, so let's talk about one of the most common sleep problems, insomnia. Let me use a different example to make an analogy. How many of you have taken your child to get their ears pierced? This is me taking my 5-year-old. In this video, you'll notice they're piercing both ears at the same time. Why? Because once the child experiences the pain of the first side, even if they really want to get their ears pierced, they're going to pull away or try to avoid the second time around, because that's how quickly the brain learns. I don't like this. I want to avoid this. Make it stop. So what happens if someone has a poor night of sleep over and over? Imagine every time they went to the mall, I took my daughter to get her ears pierced. Eventually would say, I don't want to go to the mall. And even me just talking about the mall would upset her. This is one of the key features of chronic insomnia. People will say just thinking about sleep makes them anxious. They'll say they feel extremely sleepy on the couch. They might even doze off, but the minute they go into their bedroom, they're stressed out. If you think about it, this is really actually a healthy pathway. If hundreds of years ago you were vulnerable when you slept and the places you were thinking about sleeping were stressful, you wouldn't want to sleep there for survival, right? So this conditioning, this classical conditioning, some of you may have heard of Pavlov's dog. If you took Psych 101, that when you feed the dog, you ring the bell, we develop these associations very quickly. So the dog ends up expecting to get food, even if you just ring the bell, because they've learned that association. Okay. So in sleep medicine, we capitalize on this phenomenon using 2 very valuable tactics called sleep hygiene and stimulus control therapy. These are 2 of the 5 components of the gold standard treatment for chronic insomnia, a treatment called cognitive behavioral therapy for insomnia, or CBTI. I think there's a misconception that sleep hygiene is a treatment for sleep problem, but that's incorrect. It was really meant to be used more like dental hygiene. So it's a regular practice we implement to protect ourselves and prevent developing a sleep disorder. So A lot of people wait until their sleep is bad and then they say, let me do that sleep hygiene. No, sleep hygiene, you should do it even if you're a good sleeper, even if you don't have concerns about sleep. Stimulus control therapy is also misunderstood, which I can tell you when I'm working with patients with insomnia, and having our phones in bed has made it really difficult. But stimulus control therapy, and sleep hygiene is over here on the left side. And then on the right side is the stimulus control. So, I'm not going to read this because I think all of you have heard of this, the sleep hygiene in particular, this preventative side. But the stimulus control is really about, I always tell my patients, when you go to bed, I want you to think of it like when you go to the bathroom. You don't go to the bathroom and sit on the toilet and go, I'm just going to wait until I have the urge to go. Particularly if you're having trouble with insomnia, you want to say, when do I have the urge? And then I'm going to go to bed when I feel sleepy. So the urge is to feel sleepy. And then, you know what? If I'm sitting on the toilet and the urge goes away, I don't sit there and wait till I have to go. I leave. And then when I feel sleepy again, I come back. And it's that conditioning. It's a behavioral state. Sleep is a behavioral state. And sometimes people get this dissociated. And so that's really what stimulus control is. It's potty training, but for sleep. So if any of you have a dog, if any of you have potty trained a child, that's what it is. And I think sometimes people, especially that are dealing with insomnia, they kind of overcomplicate it. They overthink it. And so just helping people just really distill it down to think about how much thought you put into going to the bathroom. It's not that much. It's just simple. When I have to go, I go. When I don't have to go, I leave. And that's really what we're trying to do, is make it less complicated. And then also using distraction to pass the time until sleepiness returns. We also avoid clock watching and then trying to get out of the bed at the same time every day. So as a final slide, I just want to say some final thoughts. There is a famous scientist that has there's a famous neuroscientist who's popularized the idea that sleep is a superpower. And I have to say, I disagree. All behaviors are designed to help us adapt to our environment. And if you think about sleep in the modern world, it's probably more accurate to say that sleep is an inconvenience. What's truer is that wakefulness is our superpower, our ability to push through the need for sleep to pursue our passions, to provide for our families, to care for our loved ones. Sleep can always wait. That's the superpower. But we have to balance this physiological need for sleep with our waking responsibilities and desires as humans. So I hope I gave you some new ways to think about sleep and wakefulness. I hope you'll understand that breathing is not less important during sleep. And I hope you'll walk away knowing that prevention is the most important strategy we have for many types of neurological diseases. So thank you for listening. I hope that was helpful, and happy to answer any questions depending on how time is.
That was amazing. Thank you, thank you, thank you.
You're so welcome.
Wow.
Okay.
Sorry, my cough. I do have a few questions, and if anybody listening right now, if you guys have any questions, please just put them on the chat box for us. Before I keep going, make sure to join our Airway Circle directory. It is the largest airway professionals Airway Circle directory in the world. We have, I think, now close to 1,000 names in there. It is free for you to join. It's free for patients to search and for providers to also search for other providers. Many times you have a patient who either moves somewhere, or you have a family member that lives in a certain city, and you're not 100% sure who they could work with. In the Airway Circle directory, you're going to find multidisciplinary professionals that could help your patients or your family members. Make sure to spend a few minutes inputting all of your info in there. If you are an Airway Circle member, you get to watch our live recordings of TNLs. We do them, many of them on Fridays. So either at 10 a.m. or 12 p.m. Eastern Standard Time. If you'd like early access to these, let us know. Today is February 6th, and we're recording this wonderful talk, and it's going to play only in April. So In April, it's going to be free for everybody to watch it live. However, if you'd like to support us into bringing these incredible resources to the community, we would love to have you as a member. Questions. You have such extensive training in the medical field, and I respect you so much. It's incredible. When did you realize that maybe the oral anatomy could be impacting your patient's sleep?
It wasn't until I did my sleep training at Stanford and I was working with Christian Guilleminault, and at that time he had passed away. He's passed away now, but there was an orthodontist there named Stacy Kuo. She's still in the Bay Area. I don't know if you know her, but
I do.
They did a lot of research together, and then we were required to spend time. And it was such an interesting experience because in that time, which was 2007, 2008, quite a while ago, that was really, people really were raising their eyebrows about that a lot, because he was the one who described upper airway resistance syndrome. He was someone who really brought recognizing sleep apnea in children. And then I kind of was able to piece together my story and how I ended up there. And that's when I realized they make you have a sleep study when you're a fellow there, but from listening to patients and being there, that's when I realized, oh yeah, I remember, I can tell my story. I had a crossbite. I have had adenotonsillar hypertrophy. I snored my whole life.
Wow.
My orthodontist said we can pull the teeth, or we can make her have gum recession and need gum grafts. Which problem do you want? Because we didn't address this until she was 10.
How did that change the way that you look at your sleep patients? Because most sleep physicians are not looking at everything that you have learned at Stanford.
Right. Well, I really want parents to be more proactive. And I think you probably deal with this too. It's hard to convince people to do something about a problem they don't see yet. So it's the subtlety of being able to show them the problem. And then I have the good fortune of working a lot with people like Becca Bachhaus just down the street. And so I think when people get a consistent message from a healthcare provider they respect, it's a little bit easier, but it still is harder to convince people to fix what doesn't seem broken.
How often do you now refer your patients to myofunctional therapy or to an orthodontist?
I mean, if it's a child, every single time I bring it up. And a lot of it's dictated, I think, by the parents at the end of the day, because I mean, working with children is very interesting because they're the patient, but they're not the decision maker. So I think trying to paint a picture for the parent to say, look, your kid might still go to an Ivy League school. They might still be a professional athlete. However, their chances of developing depression or a mental health disorder are much higher.
Wow.
Things like that. I don't know. Are there certain things that you say that you feel like help people paint that picture?
How it's related?
Well, how you convince people this is important if they're kind of skeptical when they come to your door. I don't know if I need to do this.
Yeah, it's 100% education. I mean, I use so many different analogies to drive my point, and usually they just come to my mind as I'm speaking to the patient, depending on who they are, but one of the things that we use often is if you had your tennis shoes tighten to each other, one foot to each other, could you still walk? Yes. Could you run? Maybe. You can still do these things. You're just not doing it to the full potential. So right now you're breathing, you're chewing, you're swallowing, you're speaking. However, you are restricted. If it's a tongue tie, if it's a intraoral restriction just because upper and lower jaw are too small, or if they have nasal congestion or obstruction. So you're doing the function because you have to, but you don't even know that there's a way better way to do it. And it's going to impact your own, every single system of your body is impacted whenever you're not breathing correctly during rest. What is rest? When you're reading a book, when you're sitting down studying, when you're watching TV, when you're sleeping. All of those are rest. So oral rest, posture. What are your lips and your tongues and your cheeks? And what is everything supposed to be doing when you're at rest? And how are you supposed to be breathing whenever you're at rest? If you're not doing those correctly, constantly on sympathetic system, your body thinks you're running when you're standing, whenever you're sitting down. It's just going to overwork your body. I also say if you plug your phone in on the outlet at night to charge your phone, because we have to charge our phones all night long, right? What if there's a malfunction on the cable and it charges some and it stops? It charges some and it stops. It's exactly what's happening to your brain with the lack of oxygen if you can't breathe properly. You know, if the airflow is restricted, if this tube that goes from your nose to your lungs, if it is restricted, if there's anything in there impacting the airflow, increasing the resistance, it's almost like that cable is malfunctioning. You're not getting all the oxygen that you need. So over time, it is going to impact your body. I mean, all these patients, older patients that we see with heart attack, stroke, you know, a lot of them, it's because their system was not able to heal, and sleep is healing. Anyways, I can talk about this all day if you ask me. Don't ask any questions, I won't stop talking. How does sleep disorder breathing affect the nervous system from a neurologist perspective?
Yes. Well, I think the major one is the one I touched upon in the presentation, that it blunts the wakefulness promoting systems. It also increases the sympathetic tone. So the fight, flight, or freeze branch of our autonomic nervous system. And so that is one of the reasons why we have an increased risk of things like stroke, high blood pressure, stroke, high blood pressure, heart attack. And then the other thing is breathing. It looks like some of these new studies that are coming out around the brain cleansing system. So we've probably heard about the glymphatic system that removes the waste. That is very dependent upon breathing and our heartbeat, because the arterial pulsations are what makes the fluid circulate. So just like when we walk around, like we have to get up and walk around when we're on an airplane to make our muscles move our lymphatic fluid in our legs, our arteries help move the lymphatic flow, and breathing also facilitates that.
I love that.
Yeah. So it's there are multiple ways, and it's so tied in. I mean, not to mention the cognitive function. And then if you're not getting REM sleep, you're not getting, your mental health restored every night. So there's just like a myriad of ways.
Why do you think sleep problems are often treated as neurological or psychological issues rather than airway related ones?
One, I think, is a lack of awareness. Like there's a lot of bias towards not recognizing it as a medical condition. And then the second one is, and I don't know if you encounter this, but I think because of that, people feel ashamed or defensive about it. Like we all know someone who has really obvious sleep apnea, and like their spouse is at their wit's end, but they still won't get diagnosis. It could be also in part because people perceive like, oh, I don't want the Darth Vader mask. They think that's the only option. So that's why I think you're right when you say education is the key.
What do you see for the future of sleep testing at home? There are so many companies now that are coming out just with a little finger piece. We know that it's not giving us the whole picture. However, as a parent, for example, I want to get my kids' sleep study done. I got about a month or 2 months ago, I got a machine, a Philips machine that has the chest monitor, the nasal cannula, the finger probe. My 5-year-old could not handle it at all. He could not, sensory-wise, handle the nasal cannula. He did a lot better with just a little finger thing. However, his AHI was way higher because I think it's catching everything, instead of separating arousals from full obstructions. And my 11-year-old did fine with the regular at-home sleep study when she was younger. But then this time, the same thing. She's like, nope, I'm done. I don't want to do it. So, as a mother and as a myofunctional therapist, I want my patients to be able to get a baseline sleep study. It is way easier to do something at home whenever they are in their own bed, in their own environment, without so many different um, probes and things, coming out of them, like they have to do in a sleep lab. What do you see for the future of us being able to track people's sleep and still get good numbers? Not necessarily full diagnostic, but good numbers for baselines. Is it even worth it for us to get sleep study in children?
Yeah. You'll hear different things from different people. So I'm a neurologist by training and also being trained by CG. I'm very interested in arousals and microarousals and RARAs and upper airway resistance. And with the type 3 testing, which is the nasal cannula, the chest sensor, those are called type 3 studies. They're very, very insensitive at detecting upper airway resistance and sleep apnea in thin, healthy adults and also children.
Mm-hmm.
So most of the sleep doctors in the US are, which one is that?
This one is the Prana-Q.
Okay.
That I've been studying. So it's not for children. Actually, they're an Airway Circle sponsor. They're not for children. However, I do use it on my own kids just to get, again, a baseline. But the AHI numbers were really high. Even for me, they were really high. So I was trying to understand when the Philips machine, that it's a type 3, right?
Yeah.
Were showing me from 3.2 to 6.3 AHI. Sorry. Prana-Q tip track was showing me from 3.2 to 6.3 AHI, while the type 3 was showing me a 0 or a 1.
Mm-hmm. So
both on 3%.
Yeah, most of the sleep doctors in the US are pulmonologists. They're lung doctors, and they love the flow signals. They want to see those flow signals. That's really important to them. They're really focused on the breathing. So you'll see a little bit of maybe discussion. So that's why I tend to favor a little bit more like the PAT technology, because you can see when someone has an obstructive breathing event, there is a reflex to constrict the blood vessels in the finger. You can see that. Now, what you're talking about, because I use a similar home test for kids, is you have to be able to identify electrodiagnostic artifact. And that's something that you're trained to do. It's a pattern recognition. And that's how you can say, oh, that's falsely giving me the AHI too high. That's how you would be able to distinguish that. And then also the other things you learn is, I mean, even with the one I use, if you're getting, a 70% desaturation in a young, healthy kid, like you just know it's artifact without even looking at it, because young, healthy kids don't desaturate that low unless they have, Down syndrome or they're really overweight. Like you clinically know that doesn't make sense. But to answer your question more directly, I've talked to the director of Seattle Children's Hospital about this, Maida Chen, because it's a really big issue when we're dealing with the autism spectrum, because we know those children have a much higher risk of sleep disorders and sleep apnea, but they also have these sensory issues. So even if you do have a gold standard in-lab test available, it's really difficult to get a study. So she is actually doing a study looking at a test that does not make contact at all. It's more of a nearable.
Wow.
And, even the Apple Watch, I think the way the algorithm works is actually it's measuring signals from the chest that are kind of like in the arm that it can detect from in the wrist. And so I think we'll develop these other technologies. And, I am a consultant for a company called Oslo Sleep, and they make an in-ear wearable, and it's a sleep bud that's designed to also deliver sound masking and soundscapes. And the goal of that company is to be able to read EEG, read the brain waves from something like a headphone. So these are the things I'm really excited about is, if someone is already wearing earplugs to sleep in, then it's not going to bother them to do a sleep test. And, you'll have to have different tools for different people. Some people might hate to sleep with, earbuds in, but I think ultimately it is going to be wearables and nearables. And I think the sleep lab is not really going to be, it's not going to be what it is today. It's going to kind of disappear and evolve.
That's amazing. Thank you so much for the insight. And if you guys want to learn more about PranaQ or Tip Track, go to our Airy Circle Facebook professionals page. Or if you're a member, we also have information on them with the discount code link for you guys to sign up in the discount module of your membership. If you guys need any more info, just email admin@airycircle.com. Can an Apple Watch read low on respiratory quality if a person is wearing a CPAP? What is that correlation?
I don't know the answer to that question. Maybe can you clarify what you mean by low on respiratory quality? I don't have an Apple Watch, so I guess I'm not familiar with what it reports beyond like what my patients tell me. But I'm guessing you're saying it's giving you that as a data point.
Saying low respirations, is that what you mean? Respiratory quality, if a person is wearing a CPAP.
Yeah. I mean, I don't know how they define respiratory quality, but certainly what I would say is a CPAP changes the breathing dynamics, because there's a positive pressure in the chest cavity. And that's one of the reasons why it takes people a little while to sort of get adjusted to it, is they have to adapt to that. So honestly, I would ignore it. It's probably not accurate for a CPAP user. So that's my gut feeling, but I don't know. I'll just be honest and say not familiar with their algorithms or how they define respiratory quality.
I wonder what's the difference of wearing the CPAP or not wearing the CPAP for you with the Apple Watch. I guess that's the only way for you to really tell the difference. However, if you need a CPAP, I would not recommend just sleeping with that one.
Yeah.
All righty. Well, this has been wonderful. And just to recap real quick for me to put in my brain, we have type 1, 2, and 3 sleep studies.
No. Well, yeah, I mean, theoretically, yeah, but it's type 3 and 4 that are being used. Those are the ones I think that are most commonly used. Yeah.
Which one is the lab?
In lab is a different thing. So the type 3 is what is like the nasal cannula, the chest belt, and then the type 4 would be adding on the EEG, having some kind of EEG electrode, and then there's the in-lab testing.
Okay.
I think I could be wrong about this. We can look it up later. You might be right that maybe one of them is the in-lab test, now that you say it. And I could have it backwards. It could be type 2 and type 3 we're talking about.
I need to look it up. I gotta get in my brain. Let's see. Type 1 is in-lab, being the most comprehensive for diagnosis, various disorders.
Okay.
Type 2 to 4 offers simpler home-based screening for obstructive sleep apnea.
Okay. So type 2 is probably what I was saying. Type 4 is where it's the EEG home test.
And so type 2, comprehensive portable home study.
Yeah. And then I don't know what type 4 is.
Type 3 is limited channel home sleep apnea test, the HSAT. And type 4, minimal screening study.
So that might just be like an oximetry or something.
Oxygen saturation and sometimes heart rate.
Okay.
All right.
Thank you for helping me review today.
I needed to review those in my brain also because I can't remember. All right. Perfect. Thank you so much. We helped everybody else over here remember the types of sleep studies too. Thank you so much, Dr. Meredith, for this time with us. We learned so much from you. I really appreciate you. If you ever need anything, from Airy Circle, we are here. We're so proud of you being out there and sharing all this information that you know on social media. We know that it's so important because our patients are out there and most of them do not know they have a problem. So we need people like us that are not that are shameless to go out there and keep sharing this information. So thank you so much. We really
Thank you for
appreciate
having
you.
me. Thank you. And I'm sure you'll hear from me soon because as you know, I message you all the time about things.
All right. Thank you, everybody. Have a wonderful night. We'll see you next week.
Okay,
Bye-bye.
bye.